Hello friends, I am Dr. Sanjeev Kumar, Professor of Oral and Maxillofacial Surgery at SGT University, Gurgaon. On popular demand, I am presenting an abridged version of the talk I gave recently at the UMSI State Conference at Bareilly. Through this video, I hope to clarify the confusion regarding a topic which is extremely relevant to dental surgeons in general and OMFS in particular. Facial aesthetic surgery. Who owns the domain anyway? Disclaimer: this presentation contains information available in the public domain and there is no intention of disrespecting any specialty, association or individual. The views expressed in this presentation are my personal and do not necessarily represent those of Chairman of the Fellowship Committee of AOMSI. Our specialty, oral and maxillofacial surgery, has a long history of pushing the boundaries of what we can do. Over the years, we have expanded into areas traditionally occupied by other medical fields like plastic surgery and ENT, which has sometimes led to resistance. Recently, the Indian Association of Dermatologists, Venereologists and Leprologists (IADVL) issued a warning to its members advising them not to collaborate with non-dermatologists, specifically targeting dental surgeons like us who are venturing into facial aesthetics and trichology. This situation raises a critical question. Do dermatologists have the moral or legal right to challenge our involvement in facial aesthetics? In this presentation, we will explore this question and discuss how we can strategically defend and expand our practice in this growing field. To understand the current landscape, it is important to look back at the history of cosmetic surgery, particularly in the US. After World War I, there was a significant increase in the demand for cosmetic procedures, driven largely by societal shifts and the changing roles of women. Interestingly, the early pioneers of cosmetic surgery came out from a wide variety of medical backgrounds, including orthopedic surgery, ophthalmology, general surgery, dentists, and yes, oral surgeons. This diversity of origins highlights that the field of cosmetic surgery wasn't the exclusive domain of any single specialty. As these pioneers began to formalize the field, they established various societies and academies to standardize training and certification. For example, plastic surgeons formed the American Academy of Cosmetic Surgery, while otolaryngologists and dermatologists established their own respective academies. This history shows that the field of aesthetic surgery has always been multidisciplinary, which is why our involvement as oral and maxillofacial surgeons is both logical and justified. Facial aesthetic surgery became part of the curriculum for ophthalmology, dermatology and otolaryngology, plastic and reconstructive surgery. However, several publications have revealed that trainee surgeons, irrespective of specialty, felt that their exposure to facial aesthetic surgery during their residency is inadequate and they need to undergo a thorough post-residency accredited fellowship program. Over time, as aesthetic surgery became more specialized, training programs and fellowships were developed to ensure surgeons were properly equipped to perform these procedures. However, not all of these fellowships were created equal. Many were standalone programs lacking accreditation from professional bodies. The American Academy of Cosmetic Surgery, or AACS, set some of the most rigorous standards for their fellowship programs. For instance, a fellow must complete a minimum of 125 facial cosmetic procedures, including specific numbers of blepharoplasties, rhytidectomies, and rhinoplasties. For oral and maxillofacial surgeons like us, gaining entry into these fellowships has been challenging, especially for those who follow a single degree pathway. Despite this, the training we do receive in our residency programs, particularly in orthodontic surgery and facial trauma, provides a strong foundation for entering the field of facial aesthetics. The key is to further build on this foundation with specialized training. Legal and regulatory challenges have long been part of the landscape for OMFS practicing in the aesthetic domain. A notable example is the case of Dr. Joe Naimtooth III in 1980. Practicing in Virginia, Dr. Naimtooth was charged by state medical associations of plastic surgery, otolaryngology and dermatology with performing aesthetic surgery without a medical degree. This case became a landmark because the defense successfully argued that a surgeon's competence rather than their academic degree should be the determining factor in whether they can safely and effectively perform surgery. These legal challenges haven't been limited to individual cases. In 2010, the American Medical Association launched a public campaign questioning the fitness of oral and maxillofacial surgeons to perform facial aesthetic procedures. This led to a significant confrontation where the OMFS community had to defend its qualifications and training. As a result, the American Association of Oral and Maxillofacial Surgeons, or AAOMS, redefined the specialty to include both functional and aesthetic aspects of the oral and maxillofacial region, ensuring that our scope of practice was explicitly recognized to include aesthetic surgery. Today, the field of cosmetic surgery is growing rapidly worldwide. We are seeing more and more professionals from various medical backgrounds, physicians, dentists, nurses, and physician assistants incorporating aesthetic procedures into this practice. However, the regulatory environment is highly variable, particularly in the US, where state regulations differ significantly. In some states, the laws are quite permissive, allowing a wide range of practitioners to perform aesthetic procedures, while in others, there are strict limits based on one's qualifications. In 1986, American Association of Oral and Maxillofacial Surgeons recommended enhancing the basic curriculum of OMFS in three broad areas: facial aesthetic surgery, resection and reconstruction of oral and maxillofacial cancer, and repair of cleft lip and palate. It was rightly felt that facial aesthetic surgery is a logical extension of their expertise, since awareness of aesthetics and facial balance is inherent in the planning of orthognathic surgery, of which OMFS are indisputable authorities. Additionally, OMFS has gained substantial surgical competence in the use of transcutaneous exposures in the treatment of facial trauma. Currently, CODA, the Commission for Dental Accreditation, the accreditation body for American oral and maxillofacial surgery residencies, mandates that each graduating resident must complete at least 20 facial cosmetic and/or facial reconstructive procedures. Despite our extensive training in facial anatomy and surgery, OMFS professionals still face skepticism about our ability to perform facial cosmetic procedures competently. Some argue that our residency programs do not provide sufficient exposure to aesthetic surgery and that additional post-residency fellowship training is necessary. This ongoing debate highlights the importance of ensuring that our training programs are comprehensive and recognized by regulatory bodies. In the early years of the 21st century, several Indian dentists and other medical personnel traveled abroad to attend, train, and participate in facial aesthetic workshops conducted by international or homegrown facial aesthetic specialists associations in the US, South America, Europe, and Southeast Asia. Many returned and opened their own facial aesthetic practices and training centers, especially in the metropolitan cities of India. It was all good business as there were no regulations governing the practice of facial aesthetic surgery or procedures. This situation in India took a significant turn in 2022 due to two key incidents. The first was a tragic case where a 35-year-old man named Athar Rashid died after developing Stevens-Johnson syndrome and multiple organ failure following a hair transplantation procedure conducted by unqualified technicians at a hair salon in Delhi. This case led to the High Court directive that the government frame regulations for aesthetic surgery and hair transplantation. The second incident involved a complaint filed by the Dermatology Association of Coimbatore against a dentist practicing dermatological procedures. In response, the Tamil Nadu Dental Council issued a show cause notice and declared it unethical for dentists to perform such procedures. Following these events, the National Medical Council (NMC) and the Dental Council of India (DCI) issued guidelines that significantly restricted who could perform aesthetic procedures. The NMC guidelines emphasize that hair transplants and other aesthetic procedures should only be performed by those with formal surgical training, such as MCH DNB in plastic surgery or MD DNB in dermatology. Similarly, the DCI guidelines restricted aesthetic practices to oral and maxillofacial surgeons who had received adequate training. These guidelines have effectively barred most dentists, except OMFS, from practicing or teaching facial cosmetic procedures. Both NMC and DCI guidelines stressed that hair transplantation and aesthetic procedures should be carried out only by those specialties that have their procedures in their core curriculum. Let us look at what our own curriculum mentions with regard to aesthetic facial surgery. The MDS course curriculum 2017 states, aesthetic facial surgery, detailed knowledge of structures of the face and neck, including skin and underlying soft tissues, diagnosis and treatment planning of deformities and conditions affecting facial skin, underlying facial muscles, bone, eyelids, external ear, etc., surgical management of post-acne scarring, facelift, blepharoplasty, otoplasty, facial bone recontouring, etc. Inexplicably, the requirement for any practical exposure in aesthetic procedures during post-graduation is not mentioned in the logbook format. In contrast, the NMC curriculum for MCH in plastic and reconstructive surgery provides a detailed guidelines on education and hands-on training on purely aesthetic facial, surgical and non-surgical procedures. The NMC guidelines for MD dermatology, however, does not mention hair transplantation or any extensive training in cosmetic procedures except for skin resurfacing with chemical peels, dermabrasion and lasers. Even the MS otolaryngology curriculum mentions cosmetic surgery of the nose as the only aesthetic facial surgical procedure that the trainee should undergo. So it is clear that OMFS, dermatologists and otolaryngologists are in the same boat and necessarily have to undergo further training in facial aesthetic surgeries and procedures before performing them in practice, as the curriculum of all three specialities is quite inadequate. I wonder if Dental Council of India considers these facts before reacting to complaints by IADVL against dentists. Unfortunately, the DCI guidelines have empowered organizations like IADVL to scrutinize and challenge the practices of dental professionals, adding another layer of complexity to the situation. A 2023 survey of OMFS professionals in India revealed some concerning insights. Only about a quarter of respondents felt knowledgeable about facial aesthetic procedures. This suggests a significant gap in training and awareness within our specialty. Many fellowship programs that offer training in facial aesthetics are unregulated with little oversight or standardization. These programs often fail to provide the practical experience needed to perform these procedures competently, and in some cases they may lead to ethical and legal issues for those who participate. The Dental Council of India's guidelines emphasize the need for proper training, adequate infrastructure and competent manpower for those performing aesthetic procedures. This means that OMFS professionals must seek out credible, recognized training programs if they wish to practice in this field. Given these challenges, it is clear that we need a strategic approach to secure our place in the field of facial aesthetics. One of the first steps is to adopt the AAOMS definition of oral and maxillofacial surgery, which explicitly includes the diagnosis, surgical, and adjunctive treatment of both functional and aesthetic aspects of oral and maxillofacial region. This broader definition will help us clearly communicate our expertise to both regulatory bodies and the public. We should also push to incorporate the NMC guidelines for MCH and plastic surgery into our own training programs, particularly regarding facial aesthetic surgery. This will ensure that our training is at par with those of other specialties that are currently recognized as leaders in this field. Another crucial step is to establish an association dedicated exclusively to OMFS professionals who are interested in promoting facial aesthetics. This association could serve as a platform for advocacy, training and collaboration, helping us to build a stronger collective voice. Finally, it is important to build and maintain positive relationships with other specialties such as dermatology and plastic surgery. By fostering collaboration rather than competition, we can learn from each other, share best practices, and ultimately provide better care for our patients. Singapore provides an interesting case study in how to regulate aesthetic practice. The Singapore Dental Council has issued clear guidelines that outline the training and certification required for dentists as well as OMFS professionals to perform invasive aesthetic procedures. We must support our dental colleagues by taking a page out of Singapore Dental Council's guidelines 2021. We should lobby with DCI for allowing them to practice certain procedures. In Singapore, OMFS professionals can perform procedures like derma fillers, IPL for skin rejuvenation, and various types of laser treatments, provided they have the necessary training and certification. And for more complex procedures such as blepharoplasty and rhinoplasty, they require even more stringent proof of relevant training. This model offers us valuable lessons as we work to develop our own regulatory framework in India. It underscores the importance for having clear standards and ensuring that practitioners are adequately trained before they can perform these procedures. Aesthetic surgery is unique in that it is something patients want rather than something they need. This means that patients tend to have very high expectations, and even minor imperfections can lead to dissatisfaction. Given the elective nature of these procedures, it is crucial that we carefully select our patients, ensuring that they have realistic expectations and understand the potential risks and outcomes. It is important to note that patients of cosmetic surgeries fall within the purview of the Consumer Protection Act of 2019. The field of cosmetic surgery is replete with cases of alleged medical negligence. Thus, cosmetic surgeries require certain supplementary conditions to be fulfilled before informed consent is secured by the cosmetic surgeon. Informed consent and photo documentation, therefore, is not just a legal formality but a mandate which guarantees not only the best treatment for the patient as per her or his choice, but also safeguards against unnecessary litigations. In conclusion, at least 4 medical specialties claim ownership of aesthetic procedures or surgeries. Plastic surgeons, as per curriculum, plastic surgeons can rightly claim this domain as of now. Currently dentists have been debarred from practicing facial aesthetic procedures. OMFS, oral and maxillofacial surgeons, are late entrants in this field but are most suited to pursue aesthetic surgeries because of their exposure to orthognathic surgery, etc. Training and experience prior to performing these procedures is mandatory, and informed consent and photo documentation are extremely important in this field. Thank you.